for that presentation, Geraldine, and congratulations again. And we look forward to presenting the medal. So we're now moving on to the third session, and it's an unusual session. It's the first for us in that we're having a live conversation with Dr. Mike Ryan. He is the inaugural deliverer of the John Stearne Lecture, and I would just say that John Stearne, Professor Stearne, was the founder and the first president of the College of Physicians. And interestingly, he was a doctor, a lawyer, a theologian, and a philosopher. And I think really encompassed the broad scope of medicine and its related humanities. And the aim of this Stearne Lecture is to consider that scope and those themes that maybe lie outside our normal clinical practice from day to day. So I can't think of a better person to represent and to present for the inaugural Stearne Lecture than Dr. Mike Ryan. Dr. Ryan is an epidemiologist with a special interest in infectious disease and public health. He is the executive director of the WHO Health Emergencies Programme. He has strong West of Ireland pedigree. He was born in Sligo, grew up in Mayo, and received his degree from the National University of Ireland in Galway. And initially an orthopedic trauma surgeon, he changed track to follow public health. He got an MPH from UCD. He completed his training in communicable disease in the Health Protection Agency in London and training in the European Programme of Interventional Epidemiology. He joined the WHO in 1996 and has had many leadership roles. And we'll hear a little bit about his thoughts on many issues, I'm sure, but he's worked with Ebola, he's worked with polio, he's worked on outbreaks and in the initial SARS epidemic. So he understands epidemics, he understands public health, and obviously he understands preparedness for the future. And that's what we really want to talk about today. So I want to thank Mike very much for joining us and giving us his time here today. So welcome, Mike. I think the first question, I mean, one of the things today is really, we're celebrating the end of a certain training period for trainees. They're graduating from higher specialist training. And we just had a great talk from Niamh Allen talking about, you know, avenues maybe less traveled. We're just interested in that to kick off. You took an avenue maybe less traveled in the early 90s. What drove that decision and what were your influences at that time?
Great, well, thanks, and thanks for asking me to join this gathering, and congratulations to all of you for making it this far. And I hope the toughest part of the road is behind you. You know, it was kind of imposed in a sense that I had a very bad back injury and spent a number of months in rehab and tried to go back to surgery and to finish my training, but it just wasn't possible. And I was sort of, and I must say we've all been through these existential moments, you know, when you don't get something or one particular path closes, you spend a number of months licking your wounds and trying to sort of pick yourself up. And I must say I was trying to do that, and it was actually Cecily Kelleher who had set up the Department of Health Promotion at UCG, and I remember just calling Cecily, who she didn't know who the hell I was, saying, I'm losing my mind, I need to do something, because I was literally going from physiotherapy to physiotherapy session. And going in and working in a health promotion department on some surveys was essentially occupational therapy to stop me from losing my mind. And I realized as I did that work that, you know, having spent time in Africa and having wanted to be a surgeon, because I realized that the only good doctor in Africa was the surgeon, because the nurses did everything else. That if you wanted to be the doctor in the hospital, you had to be able to operate. I realized that actually there was something else you could be. You could be a public health physician and you could make a difference. And it was really Cecily's mentorship and then going to UCD and then on to the public health, at the time it was called the Centre for Surveillance and CDSE, the Communicable Disease Surveillance Centre. Mary O'Mahony, another brilliant Irish woman, was my mentor there. I've been very lucky in terms of always meeting wonderful people who've, you know, managed to give me a steer or a push in the right direction. So to say that I planned all this is an understatement or a gross overstatement. I was very, very lucky to fall into this and have the opportunity that I've had.
Yeah, and the themes of the talk, Mike, would follow that we don't really know where we're going to end up always, and give time to let you find your feet and your own direction. And I think a lot of the talks brought that out, and indeed everyone is very proud of you and the work you're doing there. So if we might move on a little bit, just I would say it is a major understatement to say the last 16 months have been an extraordinary time for us all in terms of both professionally and socially. And I'm just interested, if you think back to predicting pandemics, you and others would have predicted it. Is this what you were thinking was going to happen when you cast your mind back to pre-COVID?
Well, we've had sort of similar events happen. Yes, it's very much that scenario. Disease breaches animal-human species barrier, silently enters the human population on one or more occasions, adapts and gets fitter and intermediate hosts, infects humans and probably adapts further. And we end up with the highly transmissible and fairly pathogenic agent that spreads around the world very quickly. Yeah, that's pretty much the scenario. The transmissibility, the route from the animal kingdom, and all of those risks we've talked about for years. And we've been piling those risks up on one side. I don't think we got the risks on the other. I think we understood those, and I think there was a general acceptance that we were at risk. Animal-human interface, exploitation of environments, population. So that idea of disease emergence was well understood. I think we've also understood that idea of propagation and dissemination and the way diseases can amplify in human populations. But we've had this sense that we could handle it. All we need was a good surveillance system, good containment, our hospital systems. We could react, build the vaccines. And I think we got that entirely wrong. We did not realize just how inflexible, non-adaptable, non-resilient, under-resourced our health systems and public health systems have been for years. We've run our health systems like low-cost airlines. We're operating on 100% bed occupancy and hoping to God nothing bad happens. We're under-resourced in key areas, under-resourced in key strategic areas that aren't just about service delivery. They're about strategic functions around laboratories that aren't just about making lab diagnosis. They're about avoiding epidemics. We don't put that into the system. We've been, hugely dependent on all of you, the frontline doctors and nurses, the doctors who've, just completely changed their practice over the last year and a half. And the world and population, citizens of Ireland, have a huge debt to the medical fraternity. I've been my own critic of the system and the medical system and everything else, but doctors and nurses, the health professions around have really stood up and really been very flexible and adapted to this. But now I hope the system doesn't think, oh, that's a big success. Let's just leave it the way it was. I think that's my fear now. So I do think we were expecting this, and I think we were completely overconfident in how the system could handle that. We expected the next pandemic to affect developing countries more than developed, that we had it. We had all the systems in place and we were going to be just fine. We just needed some vaccines and we'd get that done. So I think, yes, we've been correct and very incorrect in our predictions.
Yeah, it's interesting because we may not have shared that confidence sitting on the front line in Ireland in the infrastructure you're working in, and we might talk a little bit about preparedness later on. I suppose one of the questions that is really challenging is, when this pandemic was called in March 2020, I imagine there was a lot of competing interests and maybe barriers to moving ahead and making decisions for the WHO. What do you remember about that time? What did you learn about, the next steps along those lines? And again, it gets back to really the question you're asking about, does the world have a better understanding now, and would they move differently at that point?
I think collectively there was a very, very delayed containment response in many countries and a controlled response. There's this perception that WHO declared the pandemic in March. We didn't do that. We warned the world on January the 5th. We had messages going out to all our national focal points. We activated and told the world that we had activated our incident management system on January the 1st. And we were fully active. And warning the national focal points under the international health regulations, and each country has a formal national focal point. They were receiving warnings about this disease on January 4th and 5th with clear definitions of cases. They were being told what to watch out for. We were issuing guidance on reducing transmission in hospital settings. We were advising about PPE. We were advising about aerosol generating procedures, very much like the SARS scenario. We were already sending that information to all of the national focal points on the 5th. We had that period between the 5th and 6th of January up to about the 21st, 22nd, where it was difficult to get information. It was hard to make a proper risk assessment of what was going on. We declared a global public health emergency on the January 30th. And that's the highest level of emergency we can declare under international law. And frankly, the world just sort of stayed asleep for the month of February. And it was really in mid-March where the Director General said, they're asleep, what are we going to do? And we said, well, the only thing you can do is just use the word pandemic. It's the only thing that will actually wake everyone up. But under the agreed rules of the system, the Director General is supposed to declare a public health emergency. And when he does that, countries are supposed to act. So I think we did lose opportunities, particularly the 4 weeks of February and the 2 weeks of March. Having said that, I would say that, Ireland, and I'm sure you know where all the weaknesses are in the system in Ireland, and everyone can pick their own set of things that didn't work. But I think overall, Ireland has done a pretty good job collectively.
Yeah, and that's really important comments you made, because I think sometimes the jurisdictions, the messaging, the stuff that comes out, it is that kind of slowness at times to take that message from the WHO, and that's very interesting in the context of understanding the evolution of this. I suppose when we look then a little bit about trajectory, and I was just interested in your comments. I mean, you have that global look of this virus at the moment. There is variable epidemiology, obviously, we realize that for many reasons, but what is the trajectory globally at the moment? And when you look at the data coming out from the WHO, I mean, maybe a striking area is Africa, where the levels appear to be low. Perhaps that's not true, but what do you think is going to happen outside of variants now, but just in the overall pandemic at a global level in the next several months?
I think the point of impact of the pandemic is shifting almost every week. And there's a real north-south divide arriving or arising because of the differentials in vaccination. And vaccination is changing the dynamics of transmission and impact, but it's changing the impact dynamics more than the transmission dynamics. So Europe and North America are transforming into relatively moderate transmission zones with very low morbidity rates because of high levels of the population being protected. Unfortunately, with the arrival of Delta strain in particular, that transmission scenario is going up, which is going to generate more severe cases. Even though more people are protected, this virus is going to find the vulnerable ones who are protected much more efficiently. So we've got a more efficient virus operating in a better protected population, but it doesn't mean you're going to end up with less people in hospital or less deaths, because it's a simple equation. It's an algorithm, and that's the and I am very concerned of what's going on in Europe at the moment, and what's happening with the Delta strain is almost immediately replacing all the other circulating strains, the ancestral strain, the alpha, all of them. Very, very quickly. It's outcompeting them. This is the fittest version of this virus we have in terms of human transmission. We're not quite sure whether that is really translating into higher virulence or whether it's just the higher incidence is translating into more sick people. So it's difficult to assess. We've also seen evidence with the Delta strain that while it seems all the vaccines still seem to work against severe disease and hospitalization, certainly one dose of the 2-dose vaccines doesn't seem to be that protective against the severe disease. So it's a 2-dose regime. You needed 2 doses to be protected. And there is a big differential in the levels of efficacy against infection and then the ability to transmit. So in effect, we may be losing the benefit of vaccination as a disease control. It's a morbidity control and an impact control, yes, but we may be losing the vaccines as an epidemiologic control measure in terms of transmission. There's no real evidence that we're seeing reinfections in a sense with the Delta strain and old strains. It's all up in the air. The UK has the best data, and even they don't have a full understanding of all of these dynamics. But when you talked about the South, I'm giving you the North because that thing in football where they think it's all over. Well, Europe and North America think it's all over, and it's not for them even. But I'll tell you where it's not all over, and that is in the south, and particularly in Africa, and even in Southeast Asia. Everyone is saying the rates are dropping in India and they're dropping in Nepal, but they're increasing hugely in Myanmar, in Bangladesh, in Indonesia, and countries like that. And in Africa, we're seeing like 45% increase last week, 33% increase again this week. It's not the absolute numbers, but the incidence trajectory and the hospitalization trajectory and the death trajectory is going in the wrong direction. And for the first time in countries, particularly in the southern cone of Africa, we're seeing huge rates of hospitalization, oxygen shortages, many of the same images we saw in Nepal, we saw in India, we saw in Manaus in Brazil. We're repeating, we're almost live, die, repeat in a sense around the world. And that's all been driven by countries being essentially forced into reopening their economies for economic reasons, because people need that, but doing that in a sense for the right reasons, but with the wrong impact, because they're doing it in the context of very low vaccination coverage and extremely fragile health systems that have been through the wars. Then you add the Delta variant into that. And if you go to South Africa now, the Delta variant is massively replacing the circulating strains from previous times. So multiple factors, and Ireland needs to be very careful, because I was looking at the epi curves from Ireland today, which look excellent, right? It's flatline. But if you see what's happening in Scotland, if you see what's happening in England, and if you see what's happening in Russia and in Turkey and other places, things in Europe are really turning in the wrong direction right now. So Ireland needs to be really, really careful right now to maintain the progress it's made. It's going to be tough to maintain that progress and continue to open up in the trajectory that has been planned.
And obviously there's no easy answer to this question, but if we look at Scotland's rates yesterday, the highest they've ever reported was yesterday, and they're pushing ahead with their plans to, if you like the word, open up society. What are your views, Mike? I mean, what obviously the economy has to grow, but what sort of preparedness should we have? What would you be recommending if you begin to edge towards opening things up in society?
Well, I think it's like everything in medicine. You got to monitor the patient, and then you can change your therapeutic intervention as long as you have good monitoring in place and know when to, adapt your tactics. If you don't have the monitoring, you don't know what's going on the patient until it's too late. It's exactly the same. It's a population. So we really have to continue to focus on really good surveillance, really understanding at a micro level where the disease is. And then if we shift things and move things, we know when it's starting to go wrong quickly, and then you take early action. You don't wait for the whole follow through to adjust your tactics. You say, oh, hang on a second, that's definitely not the trajectory we want to go on. We need to go back to what we were doing before, or we need to reintroduce something. So I think flexibility in our tactics and having the ability to move those, again, we've had those ideas of subnational interventions, staying away, if at all possible, from lockdowns, trying to keep schools open. What are the priorities right now? Our priorities are to get ready for the autumn. We want our kids back in school in September. We want the kids back in college in the autumn, right? That's what we want collectively as a society. We want our workplaces to remain open. We may have to make some other sacrifices for that to happen. If you look at what's happening around Europe and in other places, it would still seem to me that gathering, particularly indoors in large numbers without physical distancing, without masks, seems to me to still be a bridge too far in the current situation with particularly with Delta variant. It's very transmissible. The question will be whether or not you can get high enough vaccination rates to really impact that, and whether whether vaccination will ultimately, in the context of Ireland, not the global context, but within the context of Ireland, will vaccination become a requirement for doing certain activities in future? With at what level? And there are whole loads of issues there on the ethics and the individual rights and conscientious objection, but it's very hard to see society in Ireland fully and completely opening up in the context of Delta until we see where this Delta thing is going. I think Ireland needs to be really, really careful, Anthony, right now.
Yeah, and we would you absolutely take that on board. And I suppose one of just a few specific questions in that regard. The rapidity and access to testing is something that this country has had different approaches to, but we'd be interested in your views on that. And rapid access to PCR And the second, the importance of rapid sequencing of viruses to understand what are the circulating viruses. What are your views on that? How would we do that in this country? And should this be centralized or should it be all over the country? How do we do this most efficiently, do you think?
Well, I always like when, testing is linked to the frontline services, be it the clinical services or the epidemiologic services. Stovepipe siloed systems don't tend to be very sustainable. I think Ireland has developed a good system of PCR-based testing. We want to see testing obviously expanded, but in a strategic way. So there's a difference. I mean, we can move PCR and supplement that with antigen-based testing in certain contexts. But obviously, antigen-based testing can be very good in the context of workplaces or schools where tests are administered by trained, not necessarily physicians, but trained technicians who can administer and interpret the test. We know that antigen-based testing is very good. You're negative, tells you you're negative. There's a lot of false positives in a low incidence situation. What do you do with them? You need to retest or do a PCR test. So it needs to be part of a clinical and laboratory algorithm. And you need to say, okay, if we're targeting a certain sector in which we want to really improve our risk management, how can we use rapid testing as part of that? And that could be in certain workplaces, that could be in schools. Then you move to the idea of self-testing and having people test themselves. And that can be a good thing too. Everyone could test themselves in the morning before they shave or brush their teeth and decide to go to work or not go to work on the basis of that test. But that's expensive. It's an expensive business. And it requires that trust in those individuals and what they do with a negative test and what they do with a positive test. That's a very complex thing. But just willy-nilly distributing tests without any plan for how they're going to be used, I don't think that benefits anybody. So I do think they need to enhance and evolve the testing strategy. And when you're in a low incidence situation, it doesn't mean you should do less testing. It means you should do more testing. And it's counter-logical, and it goes against the political way of looking at things. What do you mean? We need to look harder when there's less disease? And everyone thinks, no, we don't need to look so much anymore. That's the whole thing. Can we actually go to the Australian model, to the New Zealand model? Can we move from being, or can Ireland move from being a low incidence country to a near zero incidence country, really pushing on the public health intervention side to keep the incidence low, with high vaccination coverage, and then even in the context of Delta, use those public health and social measures, use the surveillance to keep driving to zero. We might never get there, but if we keep driving to zero, then we can keep the economy open and the schools open. My own fear is we're relying too much on vaccination as the silver bullet. And I don't think vaccination alone is our way back to school, and it's not our way back to work, and it's not our way back to having a pint of Guinness on a Friday evening. It's not alone. So I think Irish people are really good. We get that. We're not people who believe in simplistic solutions. We recognize it's complicated. Well,
it's and I would reiterate that. I mean, we've heard from different sectors, keep testing when the rates are low. It's one of the questions that came in here. We understand that, but sometimes the healthcare providers feel otherwise, and it's that investment that we would all agree with. So I think that message is really well taken. You mentioned COVID, zero COVID, and I suppose I am interested only to ask you, in the context of a virus like this, is the zero COVID attainable? I mean, you look at the Australian model, they've achieved a certain amount, but is that at a global level? Is that within the thinking of the WHO that you can get to zero COVID?
Very tough to see zero COVID in the context of the evolutionary pathway of the virus. It's evolving more quickly than our ability to contain it. But, we will have second and third generation vaccines. We may get vaccines that have a much bigger impact on preventing transmission. My grandfather used to say, young man, if you aim for the stars, you'll hit the roof. So I think we have to have that view that a zero COVID is it's a destination, it's a target. If you aim at zero COVID, you get to very low incidence. If you don't aim for zero COVID, you stay highly endemic, right? So it's a matter of which you choose as your target. I don't think achieving zero COVID right now is possible in the current circumstances, but it may be in future. And what if we do get a better and more effective vaccine? And what if that combination with really good surveillance gets you to zero COVID? We want to be ready to take that opportunity. And the only way you're ready to take the opportunity to go to zero is to have a go to zero plan already in place. Ireland is a low incidence COVID environment right now. At all costs, Ireland needs to avoid going back to a high incidence situation. Now, with so many of the vulnerable protected in Ireland, I think in terms of frontline physicians, but if we want to avoid the hospitals filling up again, it's not the coverage rate that matters. It's who is covered. So let's talk maybe of these numbers of 40% coverage and 50% coverage and 60%. It's not the people you cover that matter, it's the ones you miss. And I would prefer if physicians in Ireland were asking, who are we missing? If every GP was asking, how many people over the age of 60 in my practice have not been vaccinated? Do I know their names? Yeah. Every time a physician in an outpatient meets someone with an underlying condition who's over the age of 50 or 60, have they been vaccinated? And I would love to have the vaccine available in those settings for that sort of more opportunistic vaccination. I would much rather that the vaccination coverage of 50s and overs and people with vulnerabilities goes to 95 or 100% than achieving a spurious 70% coverage in 22-year-olds. I don't think that benefits. So I think we need to move away from coverage as a measure and talk more about missed opportunities. And who have we missed? In those immunocompromised individuals, and those people with rheumatoid, and those people with hypertension, those people with diabetes, those people over 65. Who have we missed? And have we worked with them on their hesitancy issues, on their concerns individually? If it comes down each and every single person, I would put the effort into that than achieving these numbers of saying we have 80% coverage in the overall population. Quite frankly, and you know this as physicians, that's not what matters. What matters come this winter is whether you're vulnerable and your elderly are covered. That's what's going to matter in terms of filling the hospitals up. And I think we're getting a bit, I don't know, we're getting a bit caught in the headlights of coverage as the objective. It's not. It's making sure the most vulnerable are not missed.
I mean, it's an important question. I mean, there will be a point. I mean, we obviously would agree that, I suppose protecting from disease is the first step. And obviously, these populations are variably covered. We have a relatively high vaccine uptake in this country, but we have our issues relating to how the vaccine program was necessarily rolled out. Just a question, though, if we take the point where you get to maybe vaccination to prevent, transmission, that concept, is that where we should be going, that young people should be vaccinated fully as well? Or do you feel, and I know this probably isn't answerable, Mike, but do you feel that there will be a natural immunity built up among the population ultimately to a virus like this?
Well, absolutely. It happens. It happens every year in flu. Some people get vaccinated, some don't, right? That's the reality. We've avoided the ideas of herd immunity because it was twisted into the idea that we would achieve this herd immunity by letting the virus rip, but the reality is we may end up in an epidemic on endemic situation like we have in flu. It's not the end of the world. Remember, we have an epidemic on endemic. In fact, what we have in flu is a pandemic on epidemic on endemic influenza situation all the time. That's the reality. Frontline physicians know that more than anyone else. To arrive in that situation, we are now recognizing that we have a fundamental long-term pandemic risk from coronaviruses, which is now added to the pantheon of influenza and others. We know that epidemics will occur in underprotected populations and will occur particularly where new variants emerge that escape immune protection. And we know there may be that sort of long-term low-level endemicity of the virus that keeps the virus moving at low levels. And unless we end up with a highly effective vaccine that's effective against multiple strains, and unless that vaccine protects for a long time against all forms of infection, transmission, and severe disease, then a zero COVID sort of eradication objective is probably beyond our reach. But when we look at this, then we need to look at flu, we need to look at RSV, we need to look at coronaviruses and say, okay, we're now in a world that's entirely connected, and respiratory viruses with pandemic potential are literally moving around our planet almost like air currents and like sea currents. And We're going to have to learn how to measure, observe, predict, do the weather warnings. We're going to have to learn how to prevent, protect people, and in certain cases, react to rapidly developing epidemics, no more than we do with global weather forecasting. And I think we're going to have to come to terms with a new reality.
And do you feel that policymakers have accepted that new reality? Do you think, looking to the future, that that countries,
No,
for instance, would air travel be closed down? Would there be a signal where we drop air travel and travel at a point? Is there messages out there that are resonating, do you think, across jurisdictions?
Well, I think people have understood that maybe the price of containment, if containment is possible, is a very small price to pay if you avoid a pandemic, right? So that's a proven, right? But will you convince policymakers all over the world, like in Ireland, that running your health system on 115% occupancy and basically, you know, I mean, the Irish health system can be blown over by the feather of a norovirus outbreak or a slightly bad flu season, and there's hundreds of people on trolleys. You know, are we serious that we're ready? And I think resilience, the idea that a system has built-in capacity to expand, that has that sort of extra fitness, that extra conditioning, that it can react to an exceptional situation. We have got to rebuild that elasticity. We've got to rebuild that surge capacity into our health system at all levels, right? And that's going to come with a cost. And I say it to people all the time, you know, you get your car insurance and your house insurance every year. You don't go back on the 1st of January and ask for your money back. It's still a good investment. Yeah. You know, and we don't see that. We see health as a cost. We see it as a center of cost. It's an expenditure. That's what it's called, an expenditure. And we have to shift the way politicians see health. Health is not an expenditure. It's an investment. It is a protection against worse things that could come. It's a protection against epidemics. It's a you know. So I do think, and this is, I think, where maybe the medical profession has to step up. It's one thing knowing what to do, Anthony, right? It's one thing our profession knowing what we should be doing, but we also need to become activists too. We need to get smarter at how we influence policy, smart, and not maybe always being perceived as venally pursuing our contractual negotiations with government. And this is what the citizens perceive. They don't see those physicians and frontline doctors who are fighting for the hospitals to be better funded, fighting for the system to be better. What's often projected are doctors taking care of their own interests, right? And I think we have to shift that perception amongst the public in Ireland. We've got people to go back to seeing doctors as defenders of and servants of our population who are fighting for the system to be better. And I don't know if that's necessarily, I know many of you and many people in the Irish health profession are doing that. But when you go and ask the ordinary person in the street, that's not how they perceive it.
Yeah, it's going to be a really important message. And I think we all are in this together because, you know, obviously the concept of surge capacity, not going back to where we were in 2019 and try and moving this compass along is absolutely important. There are some other questions. I hope you're okay if we just go on with a few other questions, Mike. At a global level, vaccination is something that people are interested in. You know, the data is that lower income countries is 0.8%, globally 21%. As you say, these are figures that don't reflect risk profiles. Can I just ask you about WHO and and the COVAX program from UNICEF and your thoughts on that a little bit?
Yeah, it's really you know, people are talking about COVAX and the initiative we've built over the last year. This massive capacity to deliver vaccines globally with standardized national vaccine deployment plans in each country, right? We've rebuilt much of the infrastructure for logistics and deep cold chain, the planning and the rollout of these vaccines. We've put in place the contracts to at the beginning to vaccinate 20% of the world's population. And we've built this system that works. And we have deployed vaccines in the system to 133 participating countries and economies. So we've demonstrated that we can get vaccines to countries and get them used. The problem is that's 90 million doses of vaccine compared to the, I think at the moment, just checking the numbers here, over 3 billion doses of vaccine that have been distributed in the global system.
Yeah.
We are struggling Industry is prioritizing contracts with bilateral contracts over contracts with COVAX. Countries are not sharing their vaccine. And the reality is you're 60 times more likely to have been vaccinated in a high-income country right now than you are in a low-income country. Talking about 1.2 vaccines administered per 100 people in low-income countries, 74.1 in high-income countries. The disparity is grotesque. It is frankly grotesque. I'm finding it hard, actually, Anthony, to even say the words, because when you look at this, if you looked at this in another sector, if you looked at this in the distribution of food, in the distribution of something else, it would be a scandal.
Yeah,
it would be an absolute scandal. So we have a system that can deliver. We have a contractual framework with all of the agencies have come together, put aside all of our differences, right? We've built the logistics, the procurement, and all the system to deliver this. We're missing the vaccines. And I had people the other day saying to me, well, you know, we see vaccine hesitancy in Africa, and really we're concerned about giving vaccines because they won't get used. And I nearly lost it. I swear I lost it. You know, the paternalism, the neo-colonial attitudes that we're not going to give you vaccine because we're afraid you won't use it properly. To countries who've done massive polio campaigns, massive measles campaigns, yellow fever campaigns, cholera vaccination campaigns. I mean, so there's I get energized about many things, but the current situation of vaccine distribution is horrific.
That's a really essential message for all of us and everyone listening. And our members were keen that we bring this up. And I think the unicef.ie/get-me campaign is one thing. I know it's not enough, but at least it's at an individual level that if you get your vaccine, you can give another vaccine. So it's very important to highlight that. I know we're not, but again, we have to start that process, and we're encouraging everybody to look at that particular issue, because we
need to look at it all, Anthony. I mean, it's not just a money issue. Money is great and it's fantastic to have it, and anyone who can do that, it's going to be brilliant, because it not only buys a vaccine for somebody else, but it sends a message. But we need the rich countries, we need the industrialized countries to share vaccines.
Yeah,
we need them to share. I mean, it's just wrong what's happening right now. So we need the sharing of vaccines. We need funding to COVAX to get more vaccines. We need the private companies to prioritize, and the bilateral countries need to give permission to the companies to prioritize these deliveries to the countries who have least. Because we're prepared to pay for the damn vaccine, but we can't get at the contracts because others are being prioritized ahead for long-term business reasons, and they don't want to bite the hand that feeds. That's a simple fact. The reality is there are health workers today, there are physicians, your colleagues today in many countries in the world going to work in COVID wards who are not vaccinated.
Yeah, so really important message, and I think we take the data you're showing us is something that we all have to hear, and I don't know that we're hearing that enough. The global aspects of this, of what we're doing at the moment is really important. Mike, I noted we've spoken a little bit about preparedness. I know you had an article, Variants and Vaccines, recently in New England Journal, and it outlined some of the issues. One of the listeners is asking about things like rapid response teams, a pandemic hospital. What's your thoughts on those sorts of entities, and what would you advise the health service to be putting in place as we get into the autumn and winter?
It depends whether we're talking about future epidemics versus this pandemic, right? In terms of the rest of this pandemic, I think that ability to move quickly to support parts of the system that are under pressure, that ability to move doctors, nurses, and equipment around, in other words, to move your defense to the point of impact or the point of attack. And I think people have shown great flexibility in Ireland in doing that. So I do think having rapid surge teams that can go in and help and back up and give a rest to tired doctors and nurses on the front line is a great idea. It's better done within the system and have that as a mutual support between different parts of the system, because it's more sustainable that way. But again, you need that surge capacity in the system. How can you surge to help someone when you're, if you're on the airplane, they tell you to put on your own mask before trying to assist anybody else, right? You got to be able to help the next person. So I don't like the idea of rapid response teams, sitting in some warehouse somewhere getting ready to rapidly respond. They're the last help you need, the person that's actually never worked on the front line. The best person on the front line with you is someone who's come from another front line, because they know how to operate in the environment you're working in, and they understand the limitations, and they understand how to operate in that setting. So mutual aid, mutual support, supporting systems to have a bit of extra surge capacity. We use the emergency medical teams concept. We're very highly advanced in that, standardizing that all over the world. So when you get help from another hospital in the country or out of the country, you know what the pre-qualifications are for each and every person coming on that team. And you know that they understand the system, they understand, and they will operate at a minimum level of quality and predictability. The last thing you need in a crisis is the idiot help. In a front line, in an emergency room, in an intensive care unit, it isn't the zone for best effort. That's a zone of excellence. That's a zone where you need people who really know what they're doing. And then you can have your volunteers, your medical students and others in there, but they need to be supervised. They can make a big contribution, but there needs to be a quality management system. It's not just about the numbers of bodies you throw at the front line. You've got to put people with the right training, with the right sort of mentality, with the right equipment and the right processes. And one of the big weaknesses in this whole pandemic response has been the lack of standardized clinical management, triage pathways, the patients getting into the wrong part of the system at the wrong time when they need to be on oxygen, they need to be in ICU, they're still in the emergency room. It's really about the whole system and how it works. So I do believe in that sort of rapid surge. I think in terms of coming into the winter in Ireland, that'll be very helpful. I think that enhanced surveillance coming into the winter is going to be very, very important. But most important for me will be ensuring that every doctor working in any front line is looking for that missed patient, that missed opportunity to vaccinate someone. Because the higher we get the vaccination coverage in our most vulnerable, that will determine the pressure on the health system in winter.
Yeah, and they're really practical messages, and I think it is important, just as the frontline staff, the mobilization in March 2020 was just quite extraordinary here. We can do it, but you're absolutely right, Mike. The problem is you can do it for a period of time, but there is a burnout, and you need that replenishment of energy and know-how. So we are very much committed, but we are worried. We're committed that these sort of the learning we've had in the last year is part of the future. Of course, the worry we have is we go back to same, and as you very well outlined in some of your comments. I wanted to ask you two questions. One related to something that we'd spoken about before. It was just the use of science and the use of adaptable clinical trial designs, and we had recovery, we had solidarity. One of the questions really relates to the WHO's view of that, and whether this is advocacy or implementation or operation, or how we can cut out red tape, all of these sort of things. What are your views on that?
I think we really do have to maybe rethink a bit how we do, particularly clinical research during pandemics, when we're trying to get answers quickly, definitive answers quickly that are applied across literally billions of people. So when you're making observations on oxygen or observations on interventions, right? For most of us as doctors, nurses, and physicians, our research is very important, but it's not going to change the world overnight, right? We're all operating, adding our little bit. But the observations we make in a pandemic can be applied to literally millions of people overnight. Therefore, you've got to be right, and you've got to have the best information. So knowing that hydroxychloroquine doesn't work, or an interleukin-6 inhibitor has X benefit, you need to have that information quickly. And then you need to turn that into real drugs on wards with proper clinical guidelines for the use of those drugs quickly. We've had too much, quite frankly, and it's well intended, but I'll be very blunt, Anthony, too many small trials, observational studies, anecdotal studies, and it's caused as much confusion as it has given answers. Now, we always start with that. The astute physician observing some clinical impact of using a drug and thinking, that's interesting, that seemed to help. Okay, we need that, because that's often the first insight that drives someone to do a bit of a case control study, or to do some kind of a small, not trial, but just a trial of therapy, to see, well, is that real effect or not? And it builds up to clinical trials. But unfortunately, we don't have that luxury in a pandemic because every day counts, every week counts. So how do we move quickly in a pandemic to properly mandated multi-center trials in which we can pool the information, where we have the similar endpoints, similar data collection, where we have placebo-controlled trials that we can implement in many places, but according to similar protocol. I think there is a real benefit from regional platforms for clinical trials, for that whole process to be better standardized. I mean, I'm sure that's the case in general medicine as a whole. Bigger trials are better. In a pandemic, it's absolutely vital because you have to make definitive decisions on what you're going to do. We're still getting questions on hydroxychloroquine. We're still getting questions on ivermectin because we don't have trials big enough in ivermectin to definitively say it works or it doesn't work. We're stuck in the middle. We have small trials with minimal observations, and everything is all around one, all around zero, I do think there's a massive benefit in future but we need to build those in advance, and they need to be ready to jump straight away. We're learning that through the solidarity trials, the recovery trials. We're building those pieces, and I think we'll get better at that in future. And this is really, I think, the role where clinical medicine can really take a leadership role, and not just in doing trials of drugs. I would love to know more about the impact of oxygen therapy, the whens, the wheres, and the wherefores of that. I would love to know more about clinical pathway management, triage measurements, scoring systems, all of that, right? We're not doing enough of that either, right? So it's not just about trials of drugs. It's about trials around the best clinical management methods and combinations of methods that result in better patient outcomes. And it's not always about the drug. It's about standard of care. It's about so many other issues. So I do think this is an opportunity for clinical medicine to really step forward and say, okay, we collectively in the world of clinical medicine can do preparedness for pandemics. Our preparedness isn't necessarily building labs, and our preparedness isn't putting parachutes on people like I do and dropping them into strange places. Your preparedness is building an infrastructure for rapid clinical trials, so the next time we have this, we're ready to move much more quickly on that. And that needs an investment. Again, that's more upfront investment in having that capacity to do it.
So we have to keep pushing, and I think these are great messages because we will forget, and I think we need to learn from what we've seen. I think some of these trials have been quite remarkable in their pace and productivity, and that is a reflection on the clinicians that are working. Mike, I wanted to give you just an opportunity if there's anything that we haven't covered, any message you want to mention to us, or any WH programs that you feel you would like to highlight to us before we finish up.
Nothing particularly. I just like to maybe highlight how important clinicians are in this process. I mean, for years in WHO, even we've had this epidemiologic bias, and it's all about EPIs and outbreak response and labs. And so epidemics are all about epidemiologists and laboratories and all of that. I mean, we've, I think, undervalued the role of clinical medicine in epidemic control. We've undervalued clinical infectious disease. I'm looking there. Catherine Fleming is online there, and her photo is making me homesick. Thanks very much, Catherine. I can see the blue seas of the west of Ireland, and that's making me homesick. So I do think, for me, we need to expand our clinical infectious disease service within WHO. We're not strong enough. So we're learning that there are certain aspects of our pandemic response that weren't right-sized. So I would like us to build much stronger links with the clinical services, clinical trials, clinical interventions, guidance, rapid guidance development, living guidance during epidemics, real-time electronic guidance that you don't have to wait to print out a PDF 8 weeks later, that your PDA should be updated. We're experimenting with this with clinical management of infectious disease in children, where we're using kind of algorithmic based design so that basically, once you're logged into our system, as soon as we update anything on a particular parameter of therapy, your app updates itself. You don't have to download the latest version of the guidance. So if the malaria guidance changes or the doses of the anti-malarial change, your system is updating from us. You don't have to 6 months later go on a website to say, I wonder, is there a new version of WHO's guidance on the clinical management of complicated malaria? Your system will automatically update with that information. So I think they're the things we can learn. How does clinical medicine and AI interact? How does big data and clinical medicine interact? How can we move clinical observation and clinical trials to a new level? How can we increase collaboration between clinicians and epidemiologists? All of those things come to mind, Anthony, and I think there's huge opportunities, particularly for clinical infectious disease and my world of epidemic management and to come together more successfully.
Yeah, and I think this is a two-way process. Us as frontline clinicians pre-2020, I don't think reflected much as we should have on the global side of things and the role of the WHO. So these are so important, these relationships. And as you say, infectious disease on the front line has been really powerful in this country over the last 18 months in terms of determining the pathways, the stuff that you spoke about in terms of making the right decisions at the earliest stage. But we do need to be guided by that. So I'm looking forward to the future in the context of engagement and how we can learn from this. You know, I think I think the world of medicine their eyes have been opened in the last year, and I think I'm just hoping that we can keep our eyes in the right direction. So I want to thank you for your time. We want to thank you on behalf of the Institute of Medicine for all the work you've been doing, all the guidance you've been giving, the message you've given us today. And the last bit is we'll see you out in the west of Ireland soon, so you can hopefully dip your toes in that ocean at some stage soon.
Absolutely, yeah. It's something I'm deeply looking forward to, and yeah. And again, everyone on this line and all physicians and doctors down should really take a bow. You've been magnificent, and it's made me very proud to be a doctor who qualified in Ireland. We've lots of things to fix in the system, as ever, no more than in WHO, but it fills me full of pride to be a product of the system, and looking forward to seeing many of you when I'm home.
Well, thanks again. The feeling is mutual, and I think given this is about the trainees today, I think they'd have learned a lot today as well. So thanks so much, Mike, and we'll talk to you soon, I hope. Thank you.
Absolutely, man. Talk to you.